Cái ca này đẩy cái phần đầu.
So in doing a,
Bắt đến cái phần màng.
a third trimester scan, I need to set my PRF higher. So it's gone to a PRF of 37, and I'm on, I thought, right, 23 weeks. Oh, I see, it's mid-trimester. And so I need to be mid-trimester, I need to be around about 57, that's fine, 55, 65 for the mid-trimester. So when I'm looking at the four-chamber view of heart, I do a split image, and I confirm that the stomach, I need to see the stomach. Okay, I cannot see a stomach. Or there's a very small stomach. So I need to come back later and see if this stomach fills more. But it's small. Let's see. So I have to update that, and then I split the image, and then I come up to look at the four-chamber view of heart. I first of all do this in 2D. So the first thing in working out with 2D is this size, axis, rate, rhythm, and situs. Okay. So I know the stomach's on the left-hand side, it's small. The heart is on the same side. And when I look at the heart, 2/3 of the heart is in the left hemithorax, and 1/3 of the heart is in the right hemithorax. So that's 2/3, and this is 1/3. So that's normal. So I save that image. I then come back to clearing the screen, and I look on. The image is not very good quality because of the abdominal wall. So I'm now going to select Augment. When I'm looking at Augment, I'm looking at, on 2D, I'm looking at the pulmonary veins entering into the left atrium. I'm looking at the descending aorta on the left hand side of the spine. And I'm looking at the movement of the atrioventricular valves. When I look at that four-chamber view of heart, it looks normal. I can see that the septal leaflet is a little bit lower than the mitral valve leaflet. I can see there's a atrium secundum, atrium prime, and then I can see the foramen ovale flap. All looks okay. When I'm looking at the valves, I magnify the image, and I increase my dynamic contrast, and I use slow motion to see the normal opening and closure of the valves. And I look to see the septal leaflet of the tricuspid valve is normal in its motion. So there's normal offset and there is normal motion, because I am seeing dropout here, and I'm just wondering, is there a VSD? So when I look at the valves and I see the valves are offset, I think it's okay. It looks okay. I can see the pulmonary veins are entering normally here into the left atrium, and the size of the left and right atrium are okay. When I look at the ventricles, I look at the shape of the left ventricle, which is narrow and slender, and the right ventricle, which is wider. There's no pericardial effusions. I'm still seeing dropout in the region of the ventricular septum, in the perimembranous portion of the ventricular septum. But when I'm seeing this, there is no edge enhancement. So it's probably a false positive diagnosis. But I need to check, because I keep seeing this dropout in the ventricular septum. There. Is there edge enhancement? Yes. Is there edge enhancement? No. I think there's edge enhancement. No. I can't see. So it's probably false positive. So then I move to color Doppler. A color Doppler setting is at 57 centimeters. I'm okay with that. As I come across to looking at the four-chamber view of heart, I make sure that my box is just covering the heart. I then toggle zoom to magnify the image. And then I'm looking for any evidence of tricuspid valve regurgitation or mitral valve regurgitation. If you look across the mitral valve, it's very common to have a very small degree of regurgitation, just here. This is normal. Normal at this stage in pregnancy, and more common that you would see minor tricuspid valve regurgitation in the third trimester of pregnancy. So this is normal. If I want to see whether there's a VSD here, this is not a good angle. I want the heart to be over towards the apex at 11 o'clock or the apex at 1 o'clock. Next, I'm going to rotate the probe to look at the left ventricular outflow tract. I narrow my box. I split my image into a 2D, 2DC. I ask the patient to stop breathing. And I magnify my image, and I'm looking at my left screen. Breathe away normally. So when I'm looking at my left screen, I don't look at the color when I turn it on. I'm looking at my left screen to see, am I okay? Can I see the aortic valve appear and disappear? And is the aortic valve in the center of the ascending aorta? There are 3 or 4 things you need to look: that the interventricular septum is continuous with the anterior wall, the caliber of the vessel, and the valve being in the center. Because if it's not in the center, I'm worried about a bicuspid aortic valve. But when I look at this valve, I look exactly at the point during ventricular systole, when the valve is open, to see if there's any aliasing at the level of this point here in a PRF of 57. And if I do, then I'm suspicious of aortic stenosis. This is normal. So I'm getting normal left ventricular outflow tract, and there is no wash of color in the area where I see dropout. But the dropout that I saw was not at the LVOT. The dropout that I saw was inferior at the inflow into the heart. So that's more worried about an inlet VSD. This is more the view you look for a perimembranous VSD or outlet VSD. Outlet VSD, really you look at short axis. Longitudinal axis is really perimembranous. Sorry, I just dropped that. Sorry. It's okay, this is good, thanks. Actually, I prefer the cloth, it's really good. So, next I want to look at the pulmonary artery. So as I look at the pulmonary artery, this is different to the last case because I can see a normal pulmonary valve. The last case, the pulmonary valve was thickened, but this is a normal pulmonary valve. Still, I want to look with color Doppler examination. So again, when looking at the pulmonary valve, it's very important that you do, looking at the pulmonary valve, that you see the free wall of the right ventricle. That's a very, 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 very important point. The free wall of the right ventricle. Because a lot of people look at the pulmonary artery and do not think of the free wall of the right ventricle. This structure here is the free wall of the right ventricle. Because when you want to see the pulmonary valve and get a good view of it, you have to keep the free wall of the right ventricle, and then you bring the pulmonary valve into view. If you have the free wall of the right ventricle and the pulmonary valve, that's when you will appreciate regurgitation, like you did in the last case, because you had the free wall in view. A lot of people don't pay attention to that. They come too high, they don't have the free wall in view, and they miss the pulmonary valve. So that's very important to see that. So I get the pulmonary free wall, now I've got the free wall of the right ventricle, and I've got the pulmonary valve. If I do not have the free wall of the right ventricle, I have to rotate my transducer and then bring the pulmonary valve and the free wall into view. Very important. Pulmonary stenosis is one of the most common congenital heart abnormalities, and most of these are missed on prenatal imaging because you do not do that exercise. My PRF is at 37 centimeters. Is that 57? 57 centimeters. So 57 centimeters, that's correct. But I do not have sufficient fill of the wall, so I split my image. Now I can do a number of things. The first is my power is at 92. I don't want to change my PRF. I could fill the vessel by reducing the PRF, say go down to 27. Now I have much better fill of the vessel, but then I have aliasing. That's silly. That's a stupid thing to do, because you know that the velocity in that artery is not 27 centimeters a second. You know that the velocity in the pulmonary artery is around 50 centimeters, 55 to 65 in the second trimester. So I set that number 1. Then, if I'm not getting enough fill of the valve, then I'm going to increase my acoustic output. Now I'm going to put it to up to 100. And then the third thing I'm going to do is I'm going to increase my color gain, and then ask the patients to stop breathing. Okay, breathe away normal. So when I look at this vessel, I see on 2D, and I see my color representation. And I want my color to represent what I see on 2D, because sometimes we use too much color and we have too much fill. But I can see that that is good. I have adequate representation of the fill of the vessel on that image. There is no pulmonary valve stenosis, and I have a normal trachea and I have a normal SVC. With regard to seeing an aberrant subclavian artery, this is hard at this stage, 23 weeks with a BMI. So, but to see it, this is the heart pointing towards the left-hand side, so that's the heart on the left. The aberrant subclavian is going to come off in this direction here. Now, at 23 weeks of gestation, sometimes you can see these by looking just with 2D, because if you look at this vessel here, this here is the trachea, and you can see in 2D that there's something going behind the trachea. So that fits with a sort of a picture of an aberrant subclavian. So to bring that into view, the next step is to ask, is it a vessel or not? And the only way of knowing is by putting on, because it's such a small vessel, I'm actually going to go for power Doppler. And I'm going to bring the power Doppler down and just focus over the area. And then I'm going to bring my PRF down. It's at 43. I'm going to bring my PRF down to about 15. So now I'm down at 16 centimeters a second. And when I bring it down to 16 centimeters a second, I now can see that there's fill of the vessel. When I look at the fill of the vessel, it's the same as before. There is not enough fill. So then I go to my power and I say I'm going to increase my power as the second thing I do. And then the next thing I'm going to do is slightly increase my gain. And then I'm going to ask the patient to stop breathing. And then as I magnify the image, I can see the trachea and I can see the aberrant subclavian arm. Breathe away normally. Breathe away normally. And now I have the subclavian. But you say, Simon, this could be the azygos vein. And I say, yes, it could be the azygos vein, which comes down and then looks like it drains into the SVC. So you need to see it going all the way out to the arm. I think this is going to be difficult in this patient at 23 weeks of gestation. Anyhow, you save that image. Once you have that image on view of the aberrant subclavian artery, you can also take a stick volume of this. So you press your 4D stick and you work from the top down. So you start a stick, you say I'm in the second trimester, and then the seconds you choose is 15 seconds. So she's going to have to hold her breath for 15 seconds. And at this stage, I'm only looking at the aberrant subclavian artery. So I don't really need a big depth of volume of acquisition. And then I try and bring my aberrant subclavian artery into view again. Stop breathing. Breathe away normally. Stop breathing. 5, 4, 3, 2, 1. Breathe away normally. It's a good idea to count down, because then patients understand how long they need to hold their breath for. When you accept your image, I don't want rendered image, not now. I don't think it's a very good picture. If it was a good picture, I would go to render with A plane. But I'm just going to select multiplanar and get rid of render. That makes that disappear. And now it's highlighted that I'm on the A plane, and then I'm going to select the A plane and go up in the A plane. Because it's a volume, I want to translate through the volume to see where is the information on the volume. And when I get my aberrant subclavian view, I stop at that point, because I know where's the beginning point and where's the end point. Because it may be going in a direction, in a anterior posterior direction that's not straight, like many arteries in the body, you then use VCI. And then with VCI, I want to change the background. Just bear with me. I don't like sepia, so I'm just going to go to ice. So come back to the main. So then I magnified my image until I translate through and get it. And then when I do that, I need to increase my slice thickness. And if I increase my slice thickness, I'm more likely to get the whole vessel. I did say it's not a very good acquisition, so I'm not actually catching the whole vessel. It's a very average acquisition. If it's average, I can then go back and do it again. So what you have here is you have the main Thanks. And you reduce your color threat. That's what Long has just done. To bring the vessel into view, you reduce your color threat. If you come up there, it wasn't visible. So what he did was, he held the threshold and he dropped the threshold. When you drop your color threshold, you write in more echoes. You write in more color. It's the exact same when you do with 2D. And when you write in the lower velocities, because you have a lower threshold for allowing the color to be read, it then brings it into view. So up here you can see the 3-vessel tracheal view, and now you can see your aberrant subclavian artery. You rotate your z-axis, you increase your magnification, and then you can simply start your, first of all, by the way, save it. So that's a P2, because sometimes you start manipulating a volume, then you lose it. So save it, always save it. And then you come back to it, and now you can play, and now you have on view your aberrant subclavian artery, and you can list it here, ARSA. And then you have your transverse aortic arch, your arterial duct. You can see the great arteries in view. So that's showing you how to do a stick volume analysis on a 3-vessel tracheal view. So then you can save that. Okay. That's the heart. So the other things were the corpus callosum. So for viewing the corpus callosum, one of the best ways to view the corpus callosum is to get this view of the fetal head. So if you come down through the fetal head and you magnify the image, there's one very important structure that you're looking for when you're looking at this image. So just bear with me. The baby's just moved, so I'm just going to capture the fetal profile, okay? So just let me open this image here, and then just magnify this image here. I'm on a cardiac setting, so I'm actually just going to go to a routine setting. Very quickly, while I have a routine setting on this, I'm just going to very quickly just capture a 3D. I'm looking at the prenasal space to see if there's any increased edema in the prenasal space. I'm looking at the nasal bone to see the nasal bone. I'm looking at the vomer to see the vomer is correctly positioned, and I'm looking at the jaw to see that it's in line. Stop breathing. And then I'll sort of save my image. Now this is just my rendered image of the fetal face, okay? Which I'm not that interested in, because when I look at the rendered image of the fetal face, I can see that to me, there's nothing there that troubles me with regard to the rendered image of the fetal face. And when I look at the profile, I think that the profile, if I come down, I cut right through the center of the face, and then come down and cut through the face, and I come down to the sagittal section, I can appreciate that the profile looks okay. I don't think there's any problems with micronathia. So as I save that, I'll save that image there. I'll come back to when looking at the corpus callosum. So if I come down to looking at the same image there of the baby's face, I'm going to now look at the corpus callosum. So one of the best ways of bringing a corpus callosum into view is not by doing a sagittal section of the face. It's actually, can you just roll over in your left side? That's the way. So when you're trying to get a corpus callosum, there's a very important landmark. So let me just magnify this image. So I am getting bad quality image here because I'm having problems with penetration. So I can hit the augment button to try and improve. And what I need to do is I need to try and get through the anterior fontanelle. If I can't get it with this probe, the anterior fontanelle, then I can try a C1 long. Do we have a C1 to 6?
Not here today.
Okay. Nice view of the baby's tongue, the alveolar ridge, the pharynx, the upper lip, the alveolar ridge, the nasal bone, the orbits of the eye, but not a good view for trying to get the corpus callosum. I'll come back to the corpus callosum. It's not in a good position. Thank you. If you can please come back.
Quay người lại.
Yeah. Thank you. If we come down to looking at the baby's hands, so if we look at the humerus, you see anytime I'm looking at the bones, just increase your dynamic range. Then we come down onto the picture of the baby's forearm bone. When we look at the baby's forearm bone, we sweep across to see whether we can see both forearm bones. So we can see humerus, and as I come across there, I can only see one forearm bone. So I magnify the image of that. I'm going to increase my SRI. I'm going to move that up to 4. You see the way that produces a much nicer image. And then I come across to looking at the hand, and I'm seeing the hand is held in that position. So I'm just going to take a sweep, coming across, showing a single arm bone, and then come across as a sweep to the baby's hands. And I'll save that as a clip. Once I come across to that, my next question is what is the appearances of the digits of the hands? So I come across to look at I ask myself, is a thumb present? Because with radial ray deformity, the thumb will be absent and the radius will be absent. So I come across to look at the digits of the hand. So as I do so, I see a single digit just coming in here. And I want to know is how many other digits are there. So as I come across, that's down onto the feet. The hands and feet are very close to each other. So when the hands and feet are very close, I just tap the baby to make the hands and feet separate. And if it's a difficult position for that arm, I can always go to the other arm. So what I'm seeing in the digits of the hand, if I look here, I'm seeing one digit here, one digit here, one digit here, and one digit here. So I have a very abnormal positioning of the digits of the hand, and the hand is held in a fixed flexion deformity. When I see that, I want to know, is there a thumb present? The other hand is right beside. It's difficult when the two hands are right beside each other, but when I come across, I can see a thumb, index, middle, and ring. So on that hand, if I look at the metatarsals and the digits of the hands, I look and find that on this side, that the digit on this side looks smaller when compared to the others. So I can look on back, there's clinodactyly of the index finger. So you see the tilting in of the index finger of that hand. So I have the clinodactyly of the index, middle, ring, which looks small, and then the arm bone, which is, I can only see one. I think that looks like an ulna. The shape of it is slightly more curved of an ulna, and I think the radius is missing. So that's that hand, and then you come down. This hand is more severe, the abnormality, because I'm only seeing 2 digits on this hand, and it looks like there's a cleft in this hand. So if you look at the one hand, you can see that there's a thumb, clinodactyly, a middle, a shortened ring, and I can't see a little. And on the other hand, I'm seeing a picture of ectrodactyly. So it's not, the findings in the hands are not symmetrical, which is unusual because most of these abnormalities that you see in the hands, they tend to be symmetrical. You said that the abdominal circumference was reduced. The stomach now has more fluid in it. It looks better than we started. At the beginning, we only saw a small amount of fluid in the stomach, but that's a little bit more. If we look for 23 weeks of gestation, can I show you a very useful way of measuring the abdominal circumference? Also look at the stomach. The stomach is quite posterior.
I think it's the kidney, pelvic kidney.
Oh, I'm down, am I? Too low. Oh, sorry, I am. Thank you. Thank you. Can I show you a nice way of measuring the stomach, or measuring the abdominal circumference? For all of you, you take a measurement of the abdominal circumference, you freeze the image, and then you press calc and you hit AC, second trimester. Where's AC? Here. it's a good idea to put all your measurements down here, I think, but it's up to you. And you measure the AC. And you enter your AC and you take a measurement that's saying that it's on the 13th centile, and you save that to your drive. But sometimes it's a nicer way of doing it, especially with twin pregnancies, is to press calc. It's real time. It's going straight when I press calc to freeze the image. Can we set it up that it doesn't do that? Because normally people freeze and then measure. What I do is I don't freeze, but I bring up AC. But when I press AC here to calc, it freezes. In my machine, it does not freeze, and then it allows me to go in and select AC, and the baby is still moving. And when the baby's moving, I can then change the image until I'm happy that it's inside. And when I have the image with the baby moving, I then switch from one twin to the other twin, and I make the other twin AC fit inside. And it's a very quick way for me to get a visual of how one twin's AC compares to the other. You say, Simon, why do you do that? You can measure an AC and that's 21 AC and that AC 17. I say if you do hundreds of ACs the same way, you very quickly know which is the one you worry about, and not a measurement. So measuring the abdominal circumference in patients who are large BMI and where there's oligohydramnios and you cannot see the landmarks of the skin, and you are good at measuring real time, it's a very useful skill. Yeah. So you can set up your machine so you press calc, it doesn't freeze the image. It may take too long to do that.
Tôi tưởng hỏi chị thấy đo quá chính xác.
Nhưng mà gì có thể đo
thầy cũng xài máy này được chứ không có thăm độ trên thời
Để ông có. Có cái
tức là đo trong trạng thái chuyển động free hình
tức nghĩa là bấm đo đạc nó không free hình mà nó vẫn động
đúng rồi, nhưng mà ý là mấy nó để đo nhưng mà
mình kéo sẵn cái vòng tròn xong rồi mình để quét tới quét lui cho nó nằm trong vòng tròn đó.
It's important when you see an abnormality in the hands, ectrodactyly in the hands. It's important to check that you don't have ectrodactyly in the feet. So if you split the image here, you can see the little toe, the next, and next. So you can see big toe, 1, 2, 3, 4. So there's a normal count of toes on that side. When you come across to look on the opposite side, you can see a normal big toe, and then you can see the other toe. So if you look at both feet, there's not oligodactyly and there's not ectrodactyly in this foot either. It's hard to exclude syndactyly on the toes. It's much easier to show syndactyly on the feet. But if you look at the second and third digit on the foot, you have to ask, is there ectrodactyly of these two digits? Oh, that's frustrating. So if you look at these two digits, you see the second and third toe, just check that there's no signs of ectrodactyly, but it can be very, very challenging. I can see fluid between these digits, but the second and third digits of the toe, I just wonder whether they are fused or not. Because you always ask the question but it's extremely difficult with syndactyly of the feet. But just because I know there's a problem on the hands, I want to check whether there's not syndactyly of the baby's toes. The second thing is when you see ectrodactyly, it's very important to check the face, because when you've got ectrodactyly, you may have ectrodactyly ectodermal syndrome, where you get facial clefting along with a ectrodactyly. And when I look at the baby's face there, I can see that the upper lip looks normal. If I come across there, I can see this here is called the cutaneous vermilion border. So this here is the skin here. and this here is the vermilion. So when you look with ultrasound, you can see the border between the vermilion and the skin, the vermilion cutaneous border. We miss most clefts that involve a breach in the cutaneous vermilion border where there is not a full thickness defect in the lip, because we don't look closely enough. So when you are looking at the lip, look at the cutaneous vermilion border and ask yourself, is there a defect in the border? Because you may pick up very subtle clefts that are not full thickness. So when I'm looking with this image here, I set the settings on the ultrasound system so I can see a nice continuous vermilion cutaneous border all the way across. And then I look through to the full thickness of the lip. And then in terms of seeing the full thickness of the lip, the best way to do that is to come across on an axial section through the orbits of the eyes, come down to the nasal bone, and then now you have your alveolar ridge, and you can see that the lip is intact all the way across. And then you're down to looking at the fetal tongue. Is the next patient here?
Excuse me, I think it's difficult for me to check this.
Did you pick this up prenatally on scan?
No,
Okay, yeah.
I missed this case.
I don't think that it's very strange, very lateral.
Yeah, yes.
Yeah.
It's a golden.
How can I be
It's golden hair. Is it golden? No, just the lip.
Just lip. Just
No,
lip.
the upper face is not.
Not
Yeah.
It's not hemi.
Yeah,
upper face.
yeah.
It's just the lip.
just lip.
How do I? Oh yeah.
Thế làm sao mà mình đừng bỏ sót cái này nè.
So it's got a nice vermilion
Yeah.
cutaneous border. It's got a nice philtrum. It's got
Yeah.
symmetry of the nares. It's got a normal
Yeah.
distance between the eyes. There's symmetry of the right and left face. This is just lateral.
Yeah.
Were there any amniotic bands?
No.
Does this look like
Just-
maybe a slash defect of amniotic band?
Just one abnormal isolation, not bad, not amniotic band. Yeah. Just,
Not which?
just one abnormal on the lip, not
Not deep. Yeah, no, not
Yeah.
deep. That frequently is amniotic band, a small amniotic band that affects the face. Yeah.
Maybe.
Yeah.
How to
Or pick an
penetrate-
ultrasound. Extremely difficult. There's no reported cases of mini-form clefts, microform clefts, mini microform clefts. Look it up afterwards tonight. Look up the classification of clefts after birth.
Yeah.
We don't pick any of these up. We have picked them up. I've got maybe 3 or 4 clefts because I've been looking at the cutaneous vermilion border. I haven't
Yeah.
published it. But there is a whole group of clefts
Yeah.
that you can see after birth. You've just shown one that's never been reported in the literature before. So if you've seen on the scan, then but I think more and more with these high resolution systems, we will be able to pick up these very subtle clefts. The baby's in a much better position now for looking at the heart. You want me to look at anything else? Like the corpus callosum, unfortunately, is when you were looking at the corpus callosum, the section you want to get is this section here, if I can get it. Can you go over on your side? Turn over on your side for me. Yeah, and just come back. Thank you.
Cái này sao ta?
Please tell me if I'm pushing too hard. Please tell me if I'm pushing too hard.
Cậu kêu làm gì?
Nếu mà thầy không nặng quá thì nói không chịu thì
You okay?
that's fine.
Okay. So, he's fine. So, when you are looking through the anterior fontanelle, this is not good imaging, but you just want to see the 2 lines of the genou. So you just want to see coming across here 2 echogenic lines, 1 echogenic line here and 1 echogenic line here. You want to see the genou, and when I see the genou, I keep the genou in view, and then I use my other hand and I rotate the probe. But the imaging is not good. The baby's not in a good position. So,
Biết rồi nhưng mà nhìn.
next patient I show you. Next patient I show you. All right, let's look at the next patient.